Hello, this is Dr. Kadi, and today we are going to talk about bipolar disorders. The objectives for this lecture are to discuss predisposing factors and symptomatology related to bipolar disorder, identify patient-centered care interventions in clients experiencing mood disorders, and examine the various treatment modalities for bipolar and risks and benefits of each. The DSM-5 classifies bipolar and related disorders as followed: bipolar 1 disorder, bipolar 2 disorder, cyclothymic disorder, substance or medication-induced bipolar and related disorder, or unspecified bipolar and related disorder. And remember, you can add specifiers to these classifications. So what exactly is bipolar disorder? Well, bipolar disorders are mood disorders with recurrent episodes of depression and mania. They usually emerge in late adolescence or early adulthood, but can be diagnosed in a school-aged child. However, the symptoms often look like ADHD, so kids are more difficult to assess and diagnose than other age groups. During the illness, there will be times where the individual can function normally without medication, and at other times they may experience psychotic, paranoid, or bizarre behavior during periods of mania. Care of the client with bipolar disorder always will mirror the phase of the disease that the client is experiencing. Mania is an abnormally elevated mood, and it can require hospitalization. Hypomania is less severe, and it usually lasts about 4 days with 3 to 4 findings of mania. Hospitalization is usually not required for hypomania. In a mixed episode, a manic episode and an episode of major depression is experienced at the same time. So there'd be quite an impairment in functioning, and this individual may need admission to a mental health facility. Rapid cyclers are individuals who have 4 or more episodes of acute mania within 1 year. The care of the client with bipolar disorder, again, will mirror the phase of the disease that the client is experiencing. So in the acute phase, the patient may be experiencing acute mania. Hospitalization may be required, and the goal is to reduce mania and keep the client safe. We want to evaluate if they are a risk to harm themselves or others, and if so, one-to-one supervision may be needed. In the continuation phase, we will see a remission of clinical manifestations. And the treatment during this time period is usually lasts 4 to 9 months in duration. The goal of treatment is relapse prevention through education, medication adherence, and psychotherapy. In the maintenance phase, the individual has an increased ability to function. This treatment will generally continue throughout the client's lifetime with the goal to prevent future manic episodes. So bipolar 1 disorder is when the client has at least 1 episode of mania altering with major depression. Bipolar 2 disorder is when the client has 1 or more hypomanic episodes alternating with major depressive episodes. Cyclothymia, the client has at least 2 years of repeated hypomanic manifestations that do not meet the criteria for hypomanic episodes alternating with minor depressive episodes. The following comorbidities can be associated with bipolar disorder. So substance use disorder, anxiety or eating disorders, and ADHD can also be associated with bipolar disorders. Assessment of a patient with bipolar disorder would include reviewing risk factors and risk of relapse. Genetics, such as having an immediate family member who has bipolar disorder, is a risk factor. Stressful events or major life changes can be a psychological risk factor. Physiological risk factors include neurobiological or neuroendocrine disorders, and substance use disorders could be a risk factor. Alcohol, cocaine, caffeine, or stimulants could lead to an episode of mania and relapse. Sleep disturbances could be associated with an episode of mania, and a psychological stressor could trigger an episode of mania. And this could be positive or negative stress. When it comes to genetic risk factors, this is just an FYI. For the general population, the risk of having full-blown bipolar disorder is 1%, and disorders in the bipolar spectrum may affect 4 to 6% of individuals. If a parent has bipolar disorder, the risk to each child is 15 to 30%, and when both parents have it, the risk increases to 50 to 75%.